Hello, and welcome to our program, Uterine Sarcoma, What You Need to Know. I'm Kitty Silverman, the Uterine Cancer Program Director at SHARE. Before the program begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers, and provides outreach to the general public about signs and symptoms. For more information about upcoming webinar support groups and our helplines, please visit our website at sharecancersupport.org. I'd like to welcome Dr. Nita Lee, who will be speaking about today's topic. Dr. Lee has joined SHARE twice to present information and answer questions about rare uterine cancers. And we're so pleased to have her back for this program to specifically talk about uterine sarcoma. Dr. Lee will provide an overview of uterine sarcoma and the different types of the disease and share the most current advancements in diagnosis, treatment options, and research. When her presentation ends, I'll ask her a few questions. Now I'd like to hand it over to today's speaker, Dr. Nita Lee, to introduce yourself.
Hi there. Thank you. Thank you so much, Kitty, for the invitation. My name is Nita Lee. I'm a GYN oncologist at the University of Chicago Comprehensive Cancer Center. I do surgery as well as chemotherapy and survivorship care for patients. And so I get to see patients throughout their whole spectrum of disease. I also direct our community outreach and engagement for our cancer center. And I appreciate all of the opportunities to meet and reach out to patients beyond kind of my clinical practice. So this is a wonderful opportunity. I'm going to share my screen and begin starting with our presentation today. I just wanted to let everybody know that this is a very important topic, and I'm very glad that we're covering this. I do think one of the things that can be challenging is that there's a lot of diversity to the treatment as well as to the individual diagnosis. And so this is obviously not like medical advice in per se for your individual treatments, but it could hopefully give sort of a guideline and a framework for questions that you should be asking your doctor and thinking about as you're thinking about your treatment options and or different other ideas beyond sort of surveillance and follow-up. So when we think about uterine sarcomas, I'm going to provide a overview, understanding a little bit about the diagnosis and the pathology terms, which can be very confusing, understanding some more about the molecular and genetic testing, which is changing rapidly and being both used in research capabilities as well as in treatment options, and then sort of a very broad overview of treatments, and then we'll hit some questions afterwards. So just as the basics, just to level set and have everybody on the same page, uterine sarcoma is a type of uterine cancer. As you know, the uterus here, you can actually get cancer in the lining of the uterus, which is called endometrial cancer, which is the most common cancer. 70,000 women a year are diagnosed with uterine cancer as a whole, but only 2 to 5% are uterine sarcomas. These are tumors that arise differently in the lining or the wall of the uterus as opposed to the lining. So in the muscle wall, these tumors can arise from the muscle cells that make up the wall or some of the connective tissue cells that make up the wall. So that's an important distinction. It also helps to explain why many women who have uterine sarcoma did not actually have bleeding necessarily before their diagnosis, because this is sort of hidden in the wall as opposed to kind of in the lining that has direct access out through the cervix to the vagina. Some women with uterine sarcoma will have bleeding as this starts to push into this area, but oftentimes this is only found at the time of surgery for some other reason. So there are some risk factors to know about for uterine sarcoma, though most women may not have any of these risk factors. A history of having pelvic radiation is an important risk factor. So people who have pelvic radiation for something like cervical cancer or colon or rectal cancer may be predisposed to getting uterine sarcomas many years after their radiation. So this can occur even 10, 15, 20, 25 years after radiation. Long-term tamoxifen use for breast cancer is associated with some uterine sarcomas. There's rare hereditary mutations and conditions, such as the hereditary retinoblastoma gene, which is a cancer of the eye. But in families who know this, we know that they may have predisposition towards this cancer. Unfortunately, we do know that there are disparities as well, and Black women are twice as likely compared to white women to be diagnosed with uterine sarcoma, and the reason behind that is not as clear. So, one question is, how are uterine sarcomas diagnosed? Most are actually diagnosed during surgery or really on the final pathology report. So, many times when I meet somebody who's been diagnosed with a uterine sarcoma, it's often after they've had a hysterectomy and this was found sort of on their final pathology and somewhat unexpectedly. Sometimes an MRI that is done preoperatively to work up a uterine mass, such as a uterine fibroid, can sometimes help raise concerns for sarcoma. And some patients will be referred to me to kind of do their surgery because of the concern, especially in patients who are older and postmenopausal, that increased change could be something that we would want to worry about. I think that this is an example below of just how MRI could be used. The first one shows somebody who had a leiomyosarcoma versus the second B, which shows somebody who had a just a benign fibroid, but you can see how the shape and everything else was kind of similar. So you can see how this can be very confusing without use of MRI. This is a really important area for new research that's being done using MRI technology. There's different ways of giving the person contrast and seeing how the contrast gets rapidly picked up or diffuses away to help determine like which characteristics are more associated with leiomyosarcoma. In addition, this is an area that AI or artificial intelligence and training the computer to like look at repeated images and pick out characteristics is actually also being looked at to try to help clinicians really know ahead of time what they're getting into and better counsel patients. Sometimes MRI in these research studies is matched with certain blood tests to try to use a biomarker test in addition to the MRI. Once a uterine sarcoma is diagnosed, however, I think it's very important to think about the referral to a GYN oncologist or a sarcoma expert because this is a very confusing picture, and the treatment can be very specialized based on the different types of sarcomas that we can find. So this is a very important area that I want to spend a little bit of time to thinking about understanding the pathology, tumor testing, and biomarkers. So a lot of these words get turned like thrown around, but like what does that all mean? So when I, for example, do a hysterectomy or remove a uterus, and that gets sent to the pathologist, and the first thing they're going to do is to make slides out of a really large tumor mass, and they're going to tell me what does this look like? Like what are the cells shape? What are the characteristics? And with that, that's all called histology. And the picture over here is an example of histology, what slides look like, where they're going to tell me based on like the morphology and the characteristics, like, is this a sarcoma? Is this cancer or benign? They can do different stains on the slides to see if certain proteins show up. And this kind of gives us our biggest way of diagnosing and categorizing the types of sarcomas that there might be. Importantly, though, we also know that there's a really important component of tumor genetic testing. So many people have heard of hereditary testing for such as BRCA mutations or other types of Lynch syndrome, which are not necessarily related to this right now, but there's also tumor testing that can be done on the tumor itself. So someone may not have a hereditary condition that was going to predispose their family, but their tumor has mutations, and those mutations can be very important to figure out the kind of sarcoma this is and really find potentially some targeted therapy that could match that mutation. And those are really important things to think about, and that's one of the reasons that we think about, spending a lot of time with making sure that your clinician is somebody who's, treated sarcomas, their center is someplace that treats sarcomas, so that they have the expertise of sort of their colleagues as well as their pathologist. And expert GYN pathologists are very key here. So we talked a little bit about this, but estrogen and progesterone receptors are proteins that kind of are on the outside of the cell, and some cells display those proteins, and we can use those as an advantage by giving people progesterone or giving people anti-estrogens. Additional biomarker testing is sort of also applies to kind of like what other proteins we can check. And then the terms that sometimes get used for the genetic testing on the tumor is something called next generation sequencing or RNA fusion proteins. And I'll get into this a little bit as well. So gene fusion proteins have become more and more important in terms of trying to find and figure out what drives the cancer and what could we take advantage of to try to see how we could better treat the cancer or better diagnosis if the cell look or the cells the way they're looking under the microscope are just not enough to be able to differentiate or tell the difference between the different types. So here's just an example of DNA. This is again a cartoon example of like this is like the normal way the DNA should look, for example, right? Here's one gene, here's this light blue gene and a dark blue gene. In some circumstances, you can get a mutation where, for whatever reason, one little portion of the genes are flipped around or they're translocated from one to the other. And this instead of kind of creating a protein based off of the blueprint of light blue and I mean dark blue and light blue, you get this weird fusion. So the steps of this are the DNA, which get turns into the RNA, which is the blueprint, and then turns into a protein. And this all happens within a cell. These fusion proteins are really important because these are the proteins that can actually drive a cell and turn it into cancer because these proteins can act on different elements of the cell division or the replication or it doesn't allow growth to stop, all these different things. But these fusion proteins can be very specific to each different type of sarcoma. And so thinking about how we sometimes use things of different types of testing, such as sequencing this RNA step or this fusion RNA, looking at the whole genome and seeing, are there any mutations like this? Looking at an individual protein. So those are all ways that we kind of gather more and more information about the sarcoma. And then we put that together when we're thinking about how to understand the diagnosis and then how to actually then talk about treatment changes or treatment options. So many patients are diagnosed after a hysterectomy or even after a myomectomy or a removal of a fibroid. So a couple of the key things that I mentioned before is really getting an expert pathology review. So a second opinion is a really important thing for patients who have sarcoma, in my opinion. And this can be really both for the pathology review and the treatment. The workup for if somebody is diagnosed sort of incidentally does include CAT scan, CT, abdominal, pelvis. So we want to make sure we're covering everywhere because sarcomas in the high grade types do have a tendency to go elsewhere. And this is important. Some women will be offered a second surgery, such as a full staging if on certain types. Sometimes there's a discussion of the removal of the ovaries in select cases, especially if the sarcoma has estrogen receptor positive cells. And so those are things that kind of get discussed after an initial diagnosis. When we think about staging, the staging is a little bit different than the traditional FIGO staging for endometrial cancer, which people are a little bit more familiar with. But this is kind of a little bit more basic in terms of like stage one is uterine limited, meaning it has not extended beyond the uterus. And we really divide this up by tumors that are smaller than 5 centimeters or bigger than 5 centimeters, because we do know that the size of the sarcoma at the time of presentation can tell us something about the likelihood of it coming back or the likelihood of spread. As the stages increase, we see that this could extend beyond the uterus, but still be limited in the pelvis, or it can go to other sites, including the lymph nodes in certain sarcomas. Some sarcomas, such as leiomyosarcoma, don't have as much lymph node involvement. And then finally, stage four could be when there is a metastasis or a spread of the cancer to a different location. Commonly, some of the higher grade sarcomas, like undifferentiated or leiomyosarcoma, can go to the lung or liver. And so, watching over that is going to be an important component. This is a review. This is not the whole of everything. There's some different, classifications that can be even more specific than this, but this is how I like to think about some of these tumors. Endometrial stromal sarcoma and adenosarcoma are often grouped together because the low-grade versions of these tumors tend to be a little bit more slow growing and can behave better and are sometimes treated with surgery alone. Then we have the higher grade tumors, which include uterine leiomyosarcoma, which is the most common type of uterine sarcoma that we see, as well as other things such as undifferentiated uterine sarcomas and the other types, which are a little bit more rare, but are types of sarcomas. This includes a pecoma, as well as a newer entity, not newer, but better defined entity called inflammatory myofibroblastic tumor. These tumors are all different in different ways, and they have somewhat different behaviors. But I would say that the first two types, endometrial stromal sarcoma and adenosarcoma, are the ones that are sometimes grouped separately because of their low grade nature and slightly better prognosis compared to some of the other sarcomas. And that can be difficult to hear when you have a diagnosis of this, but it's important for us to help guide the treatment. So endometrial stromal sarcomas are less than 10% of all sarcomas and represent less than 1% of all uterine cancers. This starts in the connective tissue of the uterine muscle wall. Some of the low grade things can have slow growing. There's a less chance of recurrence. The recurrence can be many years after original surgery. That can be up to like 15 or 20 years before it presents again. These are often have estrogen or progesterone receptors, and these recurrences are often found on imaging or by exam, and we often reoperate on many of these patients. So I have some patients through the years that I've operated on 3 or 4 times every several years because another recurrence pops up. Now, these can become more aggressive where it's difficult and not resectable, and there are different treatments that we use for that as well, including the hormonal options as well as other chemotherapies that we'll get to. High-grade endometrial stromal sarcoma also starts in the connective tissue of the wall, but these cells are more atypical and they generally do not have estrogen or progesterone receptor positive, and they can behave more aggressively. There's some differences between these two that are based on the cell look and the morphology, but also on kind of some of the protein status that we talked about. Leiomyosarcoma arises from the smooth muscle of the wall of the uterus, and this makes up the vast majority of uterine sarcomas. This, unfortunately, is an aggressive tumor type which is associated with a high risk of recurrence regardless of the stage of presentation. This is one that is often found at the time of hysterectomy, and as soon as this is diagnosed, we do a more full metastatic workup, such as the imaging. For leiomyosarcoma, not all of them will be estrogen receptor positive, and many women who are diagnosed at a younger age, we will leave ovaries in place if we know about it ahead of time. But at the same time, there has not been any evidence suggesting going back and taking out ovaries or removal of ovaries at the same time helps with the outcomes of leiomyosarcoma. In early stage leiomyosarcoma, there's a long history of multiple trials being done to see if we could give chemotherapy and decrease the chance of recurrence. We know, for example, even with a stage 1 leiomyosarcoma, within 5 years, more than 50% of patients will have recurred, and many patients will have unfortunately passed away from their disease. And so this becomes really urgent to kind of think about. However, many studies were done suggesting that while sometimes this may change the onset of a recurrence, it didn't change overall outcomes and was associated with a fair amount of side effect profile. So NCCN now suggests for early stage, fully resected, limited to the uterus, observation is very much recommended. Of note, for leiomyosarcomas, this is one of the sarcoma types that can also have a hereditary cancer mutation related to it, and 5 to 8% can be associated with BRCA2 mutations. And in those patients, obviously, if we find out that the person has a BRCA mutation and their ovaries were in place, we would go back to take their ovaries for the ovarian risk reduction as well. Hormonal therapy is a really important component of this, and of note, these are from the NCCN publicly available patient guides. The anti-estrogen therapy is often given for low-grade ESS, low-risk adenosarcoma, or some hormone receptor positive uterine sarcomas. Aromatase inhibitors are often given. This is a class of drugs that act on to decrease the levels of estrogen in the body. They are often, sometimes people have heard of them because they are often treated for estrogen receptor breast cancer. Fulvestrant is another anti-estrogen which works via a different mechanism for the blocking of the anti-estrogen receptor. Megestrol acetate or medroxyprogesterone are actually progesterone hormones, and progesterone receptors, when they're progesterone binds to it, it actually downregulates cancer. So ironically, we give progesterone to help treat some of these types of sarcomas. For patients who may have one functional ovary, sometimes we give a drug that's called a GnRH uh, analog, which is actually a drug that kind of tricks the body into kind of shutting down the ovarian production of hormones and kind of putting it person into chemical menopause. When we think about drug therapy, chemotherapy, targeted therapies for other types of sarcomas that are either advanced, recurrent, or inoperable, we do think about different chemotherapy regimens, and here are listed some of the regimens that are preferred. Some of the two regimens that we really think about are a drug called doxorubicin, also known as adriamycin. This is actually a very old but powerful drug. And this can be given either individually by itself as a single agent versus with other drugs in combination. One of the other combinations that's often frequently used is docetaxel and gemcitabine, which is a drug combination that can be given in addition. Sometimes the drugs that are chosen are based on the individual patient's health history. Doxorubicin, for example, does have cardiac effects, and for patients with significant heart disease or heart failure, that may not be an option for them. Other drugs such as trabectedin and other drugs that are targeted can be are approved for leiomyosarcoma, and we'll sometimes sequence these drugs in patients who have this diagnosis because there are times where the chemotherapy will work initially, but then we'll need to move on to other treatments. This other list below also lists examples of how we can really use these fusion proteins and translocation information for targeted drugs. Sometimes these targeted drugs are used in a different wide variety of sarcomas, not just uterine sarcomas, but if a uterine sarcoma has these fusion proteins or these mutations and translocations, we may be able to use these drugs to our advantage and benefit from not necessarily having to use as much chemotherapy and also have like second and third line options for patients as well. Some of these options are even given first line. For example, patients with an ALK translocation are often given one of these drugs before because of their effectiveness in this population. One of the last things that we'll talk through is the idea of monitoring for the return of uterine sarcoma. And this is very important in that, we know that can be a very scary time. We know that this can be a very difficult time, but it's also important to kind of think about how we monitor closely to see this. And so we usually use physical examinations every 3 to 4 months, especially in the first 2 to 3 years. And then we also use imaging. So unlike other CTs, other cancers where we don't necessarily image as frequently, we actually will image patients with sarcomas almost in the first 3 years, almost every 3 to 6 months, and even continue that beyond. And that's really important. Sometimes we use MRI as well, but based on sort of what your imaging was preoperatively or after surgery and the features of the cancer and how, potentially aggressive or recurrence patterns we could see, then you'll decide on like what types of imaging therapies we would be able to use. I think that ends our discussion today, but I wanted to give sort of an overview and then answer questions and just really leave you with the idea of these are things that you can bring to your doctor to kind of better understand your individual sarcoma so that they can answer a lot of these questions and really tailor that for your clinical circumstances.
Thank you so much, Dr. Lee. That was really informative. And I just have a couple of questions. Since bleeding is not as frequent of a symptom with uterine sarcomas, is there any other testing that might be helpful before
Yeah.
someone is
Before have a
diagnosed?
surgery. Yeah, it's really tough because sometimes we worry about that, right? So most of the time people get a surgery for a fibroid or they get a surgery for other conditions, or if the bleeding is not happening, sometimes people have had an ultrasound or an MRI to investigate what does the tissue look like? Are there any features of this? There are some blood tests, LDH, which is a blood test that's really commonly used in just like in part of your regular chemistry panel, has been shown to sometimes be a marker or a serum, a blood biomarker. There are a couple of other blood tests that are happening, but the hard part about it is that it's not always like suspected for this to be a leiomyosarcoma, right? And so now fibroids do not turn into leiomyosarcoma, but they can exist at the same time, or they can be mistaken for that, especially for women in their 40s. So there's a little bit of a high index of suspicion, MRI, and then sometimes people are referred at the time of their MRI to a GYN oncologist or a specialist to like review that to make decisions about what type of surgery they would have.
Thank you. Somebody asked for the very rare cancers like ESS, because the samples are so small, is it hard to know what works and what doesn't in terms of treatment? And how are cancer researchers sharing data in order to study these very rare
That's
cancers?
a very excellent question. So, yes, it is often difficult to kind of know because we won't have like a large randomized trial of, thousands of women with this cancer, right? Because, the cancer is rare and we don't get to see everybody in the same way that we would necessarily be able to study colon cancer or breast cancer. I think that it's really important for the GYN oncology community that we're often like publishing like our case series and reviews and different things like that. That's an important element of it. Just learning from the literature is something that we do. In addition, I think that's where I think having a center that sees a lot of cancers. Sorry, I thought I had a gap there for a second. That sees a lot of uterine cancers as a whole, I think it tends to be beneficial, even if you're just getting a second opinion there, because then you have sort of like the shared knowledge. For example, if I have somebody who has a new uterine sarcoma diagnosed, I often will bring them to one of our weekly conferences. So many institutions will have something called a tumor board or a multidisciplinary conference where we bring together our pathologist, our radiologist, our medical oncologist, and our GYN oncologist. And then you're kind of benefiting from sort of like the shared experience and wisdom of everybody who's treated these things through different drugs. And so we do rely on kind of our own experience, the experience of our colleagues. There are, individual researchers who are looking at ESS or looking at leiomyosarcoma that are often like, creating sort of like multi-institutional sort of research groups so that they can kind of like, get tissue together and they can actually sort of, gather more information both about the clinical experience, the treatment experience, and learn more about the pathology. So I do think that this is a really important area as data sharing has become easier and data analysis of genetics and sharing that information has become easier. We are hopeful that more rare tumor types will have that advantage of being able to, be studied better.
Thank you. And with current clinical trials, are uterine sarcoma trials always separate, or are uterine sarcoma patients ever included in other uterine cancer trials?
That's a great question. So for uterine cancer trials, they're usually not included in the same group. So most of the time there'll be endometrial cancers as the trial group or uterine sarcoma. So those usually are very separate
Hmm.
because of the behavior, the molecular tendencies, just like the overall like pathways that are turned on and off tend to be different. And so those are very much grouped separately. That being said, many leiomyosarcoma patients are actually eligible for other sarcoma trial and other sarcomas too, not just leiomyosarcoma, but there are often trials that are for sarcomas, irrespective of where that cancer started from. So, somebody who has a recurrence or a metastatic lesion, it's not just the GYN specific trials that they may be eligible for. They are often eligible for a whole other group of trials that is led by medical oncologists that are looking at sarcomas, but will have sort of like a one arm that's looking at leiomyosarcoma of the uterus versus leiomyosarcoma of somewhere else. And so it's really important. That's why I get back to like this whole idea of like a second opinion and thinking about sarcoma experts as well as another resource, because the trials options then really open up as well.
And so anyone diagnosed with a uterine sarcoma should always talk to their gyn-onc about any ongoing trials that they might
Yeah,
be.
I think so. To kind of, especially if you're faced with a situation where you're dealing with a recurrence,
Hmm.
or a
Hmm.
more advanced disease at the time of diagnosis, I think it's actually very important to kind of set up a game plan, like working with your GYN oncologist to know like, hey, what's my sequence of treatment? What are my options, right? And so sometimes for those patients, I will be thinking ahead of it, not because I want to think negatively. We're always very hopeful that the initial treatment will give us a good response, but we do know the realistic
Right.
part is that sometimes patients have to kind of be on and off treatment intermittently. And that idea of like knowing like what trials could be available, what are your specific, genetics of the tumor that we could take advantage of. Some of these drugs are already on the market, whether or not they're FDA approved yet, but they can be utilized. And some are only available in clinical trials. And so I think knowing that is a way that we want our patients to be more proactive, and the way that we kind of like approach those cancers to kind of think about, okay, downline, what are all of our options?
Sure. That
Yeah.
makes a lot of sense.
Yeah.
Somebody did ask, somebody who has leiomyosarcoma, did ask if there was a next line of treatment after doxorubicin and trabectedin.
Yeah, there are different other lines of treatment. And so that's where if you've not had some of the other chemotherapy options, for example, the gemcitabine, taxotere, docetaxel is a common regimen that gets used. Um, then we also start to think about what did the person have any fusion proteins that were particularly targetable? Were there estrogen receptor positivity? The other thing is, does the tumor itself have BRCA mutation? Because then a whole class of drugs that's called PARP inhibitors, which is usually discussed for
Mhm.
ovarian cancers in a select group, those can be utilized. Some other testing or biomarker type testing we do is to understand sort of something called the tumor mutational burden, or the genetics of that tumor, and whether or not it would respond to immunotherapy. So there's a lot of different treatments that can come up, but I hate to say that they're very tailored to like what is that individual person's tumor like. So it's harder to have like a broader scope, but I think thinking about estrogen status, BRCA status, tumor mutational burden status, eligibility for immunotherapy are definitely some of the things that we think about. And then we also think about sort of like the trials options. Some of the trials are really based on those tumor genetics as well. So some of the trials
Mhm.
nowadays are considered what's called targeted therapies, where they're looking at a profile and saying, hey, you have this genetic mutation. We have a drug that targets that genetic mutation. So those are sort of sometimes like matching trials where some people will be in it regardless of what their tumor type is, if they have that mutation. So the range is growing, which we're hopeful about, but I think it has to be very specific to that person's tumor.
That makes sense. And yeah, another person with leiomyosarcoma did ask about immunotherapy. So that could potentially be
It
a.
could be potentially, but I think not all leiomyosarcomas are going to be, respond well to chemotherapy. And sometimes we
Mhm.
try to get those other predictors to see, is there somebody whose tumor may respond better? It's not like the most straightforward first line, but I
Sure.
think that there are more investigations being done in terms of like sometimes combining immunotherapy with something else. And then also in terms of thinking about some of the more advanced immunotherapy, CAR T cell, those kinds of things are coming up, but they're really in the preliminary stages.
Okay, I think we'll wrap it up today. Thank you so much for providing such a wonderful overview and for joining us. We really, really appreciate it, Dr. Lee.
Well, thank you so much for the opportunity and for all that you guys do, because this is very helpful. And I appreciate the chance to talk a little bit today.
Thank you. Have a good rest of the day.
Okay.